your boards where you are asked to tell the patient whether the pregnancy is contraindicated. I think you should at least know those conditions very well. So one is severe pulmonary hypertension, severe systemic ventricular dysfunction with EF less than 30%, pericardial cardiomyopathy with residual dysfunction, Marfan or bicuspid aortic valve with large aorta, severe coarctation of aorta or severe left ventricle outflow stenosis, vascular Ehlers-Danlos syndrome, Fontan with any complication, severe aortic stenosis or severe mitral stenosis. You need these patients to not get pregnant. So, moving on to another patient, 26-year-old female with repaired partial AV canal and current mechanical mitral valve has found out that she's pregnant right now. Okay. She is usually in the INR range of 2.5 to 3.5 with 4 milligrams of Coumadin and wants to carry the baby. What is the most appropriate anticoagulation regimen during pregnancy? Okay. So, Coumadin throughout pregnancy, low molecular weight in first trimester and Coumadin 2 and 3, low molecular weight throughout pregnancy, ultra-fractionated heparin in first trimester and Coumadin in second and third trimester. Adult congenital heart disease 101, right? Is everybody answering? Everything is working? Yeah, right? Okay. So we are not calling on people, we're just having people anonymously respond to our questions, right? So you can answer without fear or attribution. Okay, so let's talk about anticoagulation strategies in pregnancy. This is a meta-analysis from several thousands of patients, and they talk about anticoagulation strategies in pregnancy. So let's talk about vitamin K antagonist throughout pregnancy, but this is a higher dose anticoagulation with Coumadin more than 5 milligram use. The risk to the mother is the lowest in terms of thromboembolism, but the risk to baby is the highest at close to 40%. But if the patient is on low dose anticoagulation, which is less than 5 milligrams or 5 milligrams, the risk to the mother is still low, so less risk of thromboembolism, but there is also a lower risk to the baby, which is close to 15%. With the other strategies that we discussed, the low molecular weight heparin or low molecular weight heparin plus Coumadin in trimester 3, the risk to the mother goes higher, but the risk to the baby is more or less stays the same. The ultra-fractionated heparin should not be used because there is a risk to the baby, there is also risk to the mother, so that's probably the worst kind. But the low dose Coumadin, if you're taking less than 5 years, the current guidelines are to keep that going throughout the duration of pregnancy, okay? So, but if it is higher, then you may want to consider switching to low molecular weight heparin, okay? So more than 5 in the first trimester only. So this is the ACC-AHA guidelines and PSC guidelines. So they both recommend continuation of Coumadin as a 2-day recommendation if your dose is less than or equal to 5 milligrams. Where they differ is when to start aspirin. From the ACC-AHA guidelines, they want to start aspirin in second and third trimester, but they don't want aspirin in the first trimester. The ESC guidelines are not recommending aspirin; they are just going Coumadin throughout without the use of aspirin. And in our clinic, if anybody comes for pre-pregnancy evaluation, suppose they have a borderline Coumadin dose, then we try to actually change a few things. We want to look at how much greens are they eating, are they taking any multivitamins that have vitamin K in them. So we try to change those things, dietary habits or the vitamin doses, so that we can bring the coumadin requirement to less than 5, and then that can have effects. So some of the things, practical tips that we can use. Okay, this is another common patient. Actually, this is a real patient, so they are all real in some form or the other. So 25-year-old male competitive boxer who presents for sports clearance. Okay, he has bicuspid aortic valve. He has moderate aortic regurgitation. His height is 6'5", a pretty tall dude, and his aorta measures 42 millimeters at sinuses. He's asymptomatic. Put him on cardiopulmonary exercise test, he flies through it. And so as per the ACC-AHA statement 2015 for disqualification of athletes, what is your opinion? Okay. So clear for all sports, as aorta is normal for his body size, he's a pretty tall guy. Okay. Boxing is excluded because of moderate aortic regurgitation. Exclude because boxing because of aortic dilatation. All competitive sports excluded, including table tennis. Reasonable question for the boards, right? Or in your general practice, right? Okay. So, so let's talk about those JAC 2015 guidelines that I am talking about. So, on your y-axis is that are the exercises in which the static component keeps on increasing. So by static component, what I mean is that there is increased muscle contraction, more chances of having the salva, the blood pressure goes up in that direction as you go up higher in the Y scale. On the X scale, it's more the dynamic component, it's more peak oxygen consumption, more heart rate issues. So that's how these sports have been classified into these things. So you can think of your favorite sport. I mean, if you were to look at the boxing is top right. Okay. So boxing is in the top right. So it's an extreme of static component. It's the extreme of your static and dynamic components. Generally, sports in these ones are usually okay in general. These kind of sports that are in the high static component, you have to think about when you talk about sports in a way that is it going to increase the left ventricle pressure overload or the high, or increase the blood pressure in such a way that it causes excessive stress on the left ventricle. So those are these, I guess the pointer only works here. Just only work on the screen. So those are these sports. So let's talk about the bicuspid aortic valve aortopathy. So one of the things is that even if the person is very tall, above 40 millimeter is still sort of rare. Okay, so 40, 41 is still on the extreme side of it. Yes, your aorta sizes increase with the body size, but they also tend to plateau at certain height. So 42 millimeter is not normal, okay, irrespective of the height. So if a patient has a bicuspid aortic valve aortopathy with more than 45 millimeter or 45 millimeter of aorta, the guidelines say that they shouldn't be participating in any form of competitive sports. If they are 40 to 42 millimeter in men and 36 to 39 millimeter in women, they can participate in 1C to 2C, which means anything, all of these then if you have 43 to 45, you can only participate in the 1A activities, which is basically these bowling, cricket, golf, rugby, yoga. So, and the aortic regurgitation, as far as that is concerned, because some people answer aortic regurgitation too, the guidelines in 2015 said that even if you have severe aortic regurgitation, as long as your left ventricular chamber is normal, your ejection fraction is normal, and your exercise capacity is normal, they said that they can participate in all forms of competitive things. So severe aortic regurgitation is not contraindication. Okay. So moderate aortic stenosis is, but not severe aortic regurgitation. I guess moderate aortic stenosis causes more alveolar overload doing these things than aortic regurgitation. Okay, that's it. Questions?